From RBC Consultants. Welcome to another International Dermatology Education Foundation educational series webinar. This evening, we're going to be talking about shared pathways, clinical insights across skin and joint. Our moderator this evening is Dr. Jordan Talia, who is the Assistant Professor of Dermatology, Director Complex Medical Dermatology, and Director of Skin of Color Center in Kimberly and Eric Waldman Department of Dermatology at Mount Sinai in New York. Our speaker this evening is Dr. Joe Tung, who is Director, Clinical Trials Unit and Medical Director at Falk Dermatology, Associate Director, Dermatology Residency Program, Department of Dermatology at University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania. We'd like to thank our supporter, Johnson & Johnson Innovative Medicine, for making this educational event possible. Before we begin, let me bring you through a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial information will be presented to you. At the end of this webinar, a survey will pop up in your browser and will be emailed to you 1 to 2 days later. We greatly appreciate it if you could fill it in and send it back to us. If you're having issues hearing the webinar, please submit your questions in the question chat pane and we will assist you. And within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. Again, if you'd like to submit questions to our faculty, please submit your questions in the question chat pane on the right-hand side of your screen, and I wrote a note there so you can see exactly where you need to type in your questions. So without further ado, I will pass the floor virtually to Dr. Talia.
Thank you so much, Roxanne. I appreciate it. I'm Dr. Talia, everybody, and looking forward to moderating today's session with Dr. Tung today. So just as a reminder for everybody, this is a presentation brought to you by the IDEF, which is the International Dermatology Education Foundation. IDEF is a nonprofit organization whose principal mission is to raise awareness and improve dermatologic care all over the world through education, especially in underserved areas. And I'm honored to say that the president of the IDEF is Kircik, a colleague of mine. The IDEF is very well known for its previous educational sessions, which were done throughout the time of the pandemic, as you can see here, and looking forward to be able to provide the same education for you today through today's session. If you'd like to stay up to date with the IDEF educational series webinars, that can be done through Instagram, LinkedIn, and Facebook. As well as the website found below to register for upcoming educational events. And without further ado, Dr. Joe Tung will be presenting shared pathways, clinical insights across the skin and joints.
Thank you very much, Dr. Talia, and thank you, Roxanne, as well. So today we're going to be talking about shared pathways and clinical insights across the skin and joints. I'll be presenting a lot of clinical trials data today, as well as mixing in some of my experience working with patients here in the Pittsburgh area. Thank you all for tuning in tonight and spending some time on a Wednesday with us. And today we're going to specifically be talking about Tremfya for our patients with psoriasis and psoriatic arthritis. Tremfya is the only interleukin-23 inhibitor proven to significantly inhibit structural damage progression in our patients with psoriatic arthritis. We'll definitely go into greater detail later on in the talk here. On the bottom here, I also like to highlight that Tremfya recently got its FDA approval for pediatric patients 6 years of age and older who also weigh at least 40 kilograms as well. So it is the only interleukin-23 specific inhibitor that has this pediatric indication now as well. Important safety information here. What I love about this for Tremfya is that everything just fits nicely on one page, on one slide here. We'll definitely go into each of these separately as we go along the talk here, but big picture wise, if a patient has a hypersensitivity reaction to Tremfya, so if they have an allergic reaction to Tremfya or any of its excipient, as you would with any therapy that you give patients, you would not give a patient a medication they're allergic to. We'll talk about infections, we'll talk about TB, we'll talk about hepatotoxicity, immunizations, and some of the adverse reactions later on. But what I love about this medication is all of this important safety information that patients get in the package insert all just fits on one slide here. Program disclosure, as you guys know, this is a promotional educational activity, so we are going to stay on label during the duration of the talk. Of course, afterwards, if you have any off-label questions, I'm happy to take that in a one-on-one setting afterwards, or connect offline to discuss anything, but we will stay on label during the duration of this talk. What is amazing in the field of psoriasis and psoriatic arthritis in the year 2025 is we finally have therapies that can reach this holy grail of treatments, right? The trifecta we've always looked for in psoriasis and psoriatic arthritis. Number one is skin clearance. And I think that's so important that we're talking about clearance now. We're no longer in the days of talking about PASI 50 or roughly 50% improvement in your psoriasis. We're past the days of talking about PASI 75. Now we're really getting to skin clearance. And I tell all my psoriasis patients this. When they're in my clinic, my goal for that patient is to get their skin to being completely clear. But not just thinking about the skin. So I also run the rheumatology, dermatology combined clinic here in Pittsburgh, where I see a lot of our psoriatic arthritis patients jointly in the same clinic with our rheumatology colleagues. And so doing a lot of joint exams, and we really want to focus not just on joint improvement for patients with active psoriatic arthritis, but also really shifting that timeline forward to thinking about how do we even prevent the progression of joint disease. We'll go over some really exciting data around that later on in the trial as well. And of course, efficacy always has to be balanced by safety, and so safety profile, supported by long-term follow-up data. Is it possible to deliver all three? And in the year 2025, with our new agents, we are able to do this. So I will go in a stepwise manner to go through those three parts. Tremfya, so we'll explore some Tremfya data from pivotal studies in adults with moderate severe plaque psoriasis, as well as its active psoriatic arthritis trials. We'll talk a little bit about the burden of structural damage in active psoriatic arthritis using the clinical case study. And then we'll go over some new data that just came out this year from the APEX trials with Tremfya, as well as discuss some potential implications for addressing structural damage in adults with active psoriatic arthritis. This is about as basic science as we're going to get here, but I think this is really important to understand and to convey to our patients as well when we think about therapeutics for psoriasis and psoriatic arthritis. Tremfya is the only fully human selective dual-acting interleukin-23 inhibitor. So we know the mechanism of action of this medication kind of goes in two ways. The bigger action here is that it targets the P19 subunit of interleukin-23, and that's a board exam question as well. We need to know Tremfya targets it's a P19 subunit of interleukin-20. That's how it impacts 23 function. The second part of it is actually in this FC region, so the heavy chain of this antibody, and that is where it has this native antibody that is able to bind to CD64. We'll go over the importance of this a little bit later on as well, but where is CD64 expressed? It's expressed on the monocytes, macrophages, and dendritic cells, so the immune cells that actually produce the interleukin-23. So again, two parts of the mechanism of action. One part is actually blocking that P19 subunit, inhibiting downstream interleukin-23 function. The second part is binding to CD64, which is expressed on the cells that actually produce interleukin-23. Now, how does that make Tremfya structurally different? How does it make it unique? We do have other interleukin-23 inhibitors on the market. This is a diagram that shows the key differences between Tremfya and Skyrizi here. Of course, both molecules are very effective in psoriasis as well as psoriatic arthritis. Both do target the P19 subunit, and through that inhibits the interaction with the interleukin-23 receptor. There are two main differences, though. The first one is that Tremfya is the only one that's fully human. So it's the only fully human antibody, where Skyrizi is a humanized antibody. And what that means is effectively Tremfya has a wild type configuration in its FC domain. If we think back to our biochemistry classes, we know that every antibody has kind of two main components that are important to know. The first part is what we consider the antigen recognition domain. This is that domain that's different between antibodies, and for Tremfya, this is the one that binds to the P19 subunit of IL-23. The second component is on that heavy chain of the antibody. This is that FC domain, or the constant domain between antibodies, and Tremfya has a wild type configuration here, where Skyrizi has a LA mutation in this FC domain. So Tremfya is able to bind to CD64, which again is expressed on the monocytes, macrophages, and dendritic cells that actually produce interleukin-23. Skyrizi is not able to bind due to this LALA mutation on the FC region. Of course, I have to point out at the bottom, this difference in clinical pharmacology cannot be used to establish definitive differences in efficacy or safety, but these are a couple of the differences when people ask about, what is structurally different between Tremfya and Skyrizi here. Now, how does awareness of the dual mechanism of action of Tremfya factor into decision-making for appropriate patients? We really have to think about psoriasis as not just a skin disease, but a systemic inflammatory disease, right? So we know, and I talk to my patients about this as well, psoriasis is not just a disease where you see these pink plaques on the surface of your skin. I tell all my patients, what I cannot see with my eyes, but what I know is going on inside your body is the same level of inflammation. We know psoriasis is associated with a lot of different systemic conditions. Patients with moderate to severe plaque psoriasis do have elevated risks of things like arthritis, major adverse cardiovascular events. Patients do have higher coronary plaques when we take a look under imaging. Patients are associated with inflammatory bowel disease as well. So this is not just inflammation localized to the surface of the skin. We really have to think about psoriasis across a range of different disease processes. And thankfully, Tremfya has really good data across all these domains. Johnson & Johnson has really invested the infrastructure and into clinical studies to look at high impact sites of involvement, think spots like the scalp, the nail, the palms and soles, as well as patients with different body weights. So we know across all different areas of involvement, all different types of patient subpopulations, there is really robust data to show that it works. We'll go over some of these data later on in this talk as well. Across all skin tones as well, there's a separate clinical trial called the Visible study, for which we were a part of. So I saw a lot of patients in the study where we enrolled patients across the entire spectrum of skin tones and showed that this medication works well, not just in our typical patients, but across all skin tones. Different active psoriatic arthritis domains. We know there are 6 main domains for psoriasis and psoriatic arthritis. Those 6 are your peripheral arthritis, your axial disease, dactylitis, enthesitis, skin disease, as well as nail disease. So those 6 make up your psoriatic arthritis, psoriasis domains, and Tremfya has really good data across these sites as well and across different patient subpopulations. Now let's jump straight into the clinical study. So here in the United States, in order for the FDA to approve any medication, you need to have 2 parallel arm studies. So that's what these pivotal studies are for Tremfya. They're called Voyage 1 and Voyage 2. Effectively, what the FDA wants to know is that across 2 different study populations, different investigator sites, different principal investigators, you're able to reproduce your results, right? You cannot just have a clinical study, even if it's a phase 3 study in one specific patient population or one specific geographic area. The FDA wants you to be able to reproduce this across 2 different sites. So that's what Voyage 1 and Voyage 2 are for psoriasis for Tremfya here. And as someone who does a lot of clinical trials, there are 3 main things I take a look at and I focus on when I look at any kind of clinical trials results. The first thing I look at is this nice separation between the active medication arm and the placebo arm. Right, so I want to be able to tell that this medication works, not just statistically different, but also clinically meaningful difference. And as someone, I'm the investigator in the studies, I'm always blinded, right? These studies are always done in the double blind fashion where I don't know whether the patient is receiving a placebo, just a sugar pill, sugar injection, or whether that patient's getting the actual medication. But there are certain studies like these studies that we're showing here, Voyage 1 and Voyage 2 with Tremfya, where even though I'm blinded and I don't know what the patient's getting, I actually have a pretty good idea whether that patient's on active medication or placebo. That's what I like to see in a clinical trial. This nice separation where 73% of your patients are achieving your primary endpoint compared to just 3% on your placebo arm. So, and this is looking at really stringent endpoints, PASI 90, one of the first medications in psoriasis to be looking at PASI 90, which roughly is a 90% improvement in your psoriasis when you take into account body surface area involvement, erythema, the induration, the scaling of your psoriasis as well. IGA 0/1, on the other hand, is looking at IGA 0 basically means complete clearance of your psoriasis, not a single plaque left on the body. So going back to thinking about my goal for psoriasis patients, complete clearance, that's your IGA 0. IGA 1 means you're almost clear. You might have 1 or 2 small spots left on the body, but clear to almost clear, 85% on Tremfya versus 7% on placebo. So that's the first thing I take a look at with clinical trials. The second thing I look at is the same thing I talked about with what the FDA looks at, which is that reproducibility in your results here. And so Voyage 2 results are here on the right-hand side. You see 70% in Voyage 2, 73% Voyage 1. And then your IGA 0/1, you're seeing very good consistency, 84 to 85%. What this indicates is basically across different geographic areas, across different patient subpopulations, across different investigators doing the actual assessment, you're getting really good reproducibility of your results. The third thing I look at with clinical trials is actually these 3 letters up at the top, NRI. What NRI stands for is non-responder imputation, and that is basically the most stringent way you can do any kind of statistical analysis for clinical trials. What non-responder imputation means is that if a patient were to drop out of this clinical trial for any reason at all during the course of this study, that patient is now considered a treatment failure. Okay, so as someone who does trials, there are a lot of different reasons why patients might drop out of a clinical study before the study ends. In fact, I have patients who get so much better, their psoriasis is now completely clear, and for that reason, now they're going back to living the life they want to live. They can go on vacation again without worrying about a breakout of their psoriasis. You know, they can actually go back to work again. And for those reasons, they no longer have time to stay in a clinical study. Clinical trials can take up a lot of time with weekly or every other week visits. But for that patient who went back to work, so for that reason, they're dropping out of the trial, even though their psoriasis got so much better, they're considered a treatment failure because they stopped participating in the study when you have an NRI way of statistical analysis. So the reason why I spend a little bit of time kind of focusing on this NRI statistical analysis is because oftentimes in my experience, when you have a clinical study that has statistical analysis done under NRI, in the real world setting, you actually even see better results for your patients here. So really important to have clinical studies that have a non-responder imputation statistical analysis. These are some sample pictures. You know, these are not my patients, but they're very representative of many of the patients I see in my clinic. This is the baseline. You see this characteristic psoriasis on the characteristic area, which is the knee here, and you see these pink scaly plaques, very thick and indurated as well. This is a PASI 14. And on week 16, this is after just 3 doses of the medication on week 0, 4, and 12. This is PASI 1.8 or roughly 88% improvement. Same deal on the patient on the right, roughly 77% improvement in their psoriasis. What I think is really important to highlight here is both of these patients here are actually considered treatment failures in the eye of the FDA. Remember, our primary endpoint from the previous slide is that really ambitious, really aggressive PASI 90 as your endpoint. So neither of these patients actually reached PASI 90. This was a PASI 88, and this was a PASI 77. So both of these patients actually fall into the category of non-responders in the eyes of the FDA. But I'll tell you, and you guys will know this as well, when you see this patient back in clinic, who goes from baseline on the far left here to week 16, at a 4-month check-in, and they're looking at like this on the right, that is one happy patient. So even though in the eyes of the FDA, with the PASI 90 as your primary endpoint, these are considered treatment failures. These are really happy patients. So even the ones who do not achieve that PASI 90 response, the picture really tells the story there. The other thing that's really important for our psoriasis patients is durability in your response rates over time, right? A lot of our older biologic agents, we see what we consider more of a sawtooth pattern, where you have patients losing their response with time, or patients not able to make it to their next dose before they have a flare. But now we have out to 5 years of data with Tremfya here. Week 252 here, 5 years of data showing a nice flat line in both your PASI 90 as well as your IGA 0. Basically, this is showing us that patients who are better on Tremfya do not lose their response over time. They do not build up antibodies to the medication. They do not lose their efficacy. So this is one of those medications, I call it a set and forget medication, where you get patients started on it, you do that prior authorization once, and then that patient is really just following up once a year for refills because they're so happy with the results they see. And this is what that data is showing. Nice flat line over time. When we start thinking about special sites of involvement here, some of the tougher to treat sites are your scalp, and this is scalp clearance rate. So basically complete clearance, IGA 0 or 1, so clear to almost clear. 83% of your patients at the week 16 time point are able to reach this major secondary endpoint. Again, this is with a non-responder imputation analysis as well. Out to the week 48 mark, very consistent. Patients are not losing response with time. 8 out of 10 patients having scalp psoriasis in the studies, and they respond really well to Tremfya. Some pictures here as well, showing this 2-grade improvement in your IGA response, baseline to week 48. Same deal here, on the pictures on the right here, you see these pink plaques in the scalp, oftentimes recalcitrant to some of our traditional agents, and topical medications oftentimes get a little messy for the scalp. But with Tremfya, this patient was able to get to 100% clearance on their scalp. Other special sites of involvement, the nail and the palms and soles showed really great clearance as well. Now remember, our nails grow very slowly, right? Fingernails grow at a rate of 0.1 millimeters a day, or roughly 3 millimeters a month. And so for nails to fully grow out, that takes about 4 to 6 months, which is why, when you take a look at week 16 endpoint as your first endpoint, 34% of patients getting to complete clearance for their nails at the week 16 time point basically means at week 0, after that first dose of medication, they're already having complete clearance. And then for that nail to grow out, takes about 4 months there. So at week 48, is a more appropriate time point to take a look at your nails. That's when you've gotten a full cycle of your nail growing through. 68% of patients got to complete clearance there. Same thing that you're seeing with your palmar clearance on the right side as well. Even in special size involvement, in fact, Johnson & Johnson has a separate study specifically looking at special size involvement called a spectrum study. We won't have time to go into the details of that study, but that looked at these high impact sites. Very classic, thick indurated plaques on the left on the hand, getting to 91% improvement at week 48. Palmar involvement, even though this is a small body surface area of involvement just on the palm, we know this has an outsized impact on the patient's quality of life, right? Think about all the people who have to work with their hands. I see a lot of healthcare professionals with palmar involvement, where even though it's 1 or 2% of their body surface area, it really has a tremendous impact on their ability to carry out their activities of daily living here. So good clearance with Tremfya here as well. Now, of course, I always like to balance out any talks of efficacy with the safety data. Thankfully for Tremfya, this is a really easy slide to go over. I just want to point your attention to a couple things here. Very consistent in terms of your adverse events. It had a head-to-head against Humira as well as against placebo. And we'll talk about some of the things I counsel patients on later on in the talk, but very consistent in terms of things like infections, serious adverse events. Out to 5 years of data here, very consistent, nothing new that we're seeing here. What do I actually counsel patients on? Couple things. Number one is injection site reaction. So with any of our injectable biologic agents, I always counsel patients just at the spot where you're getting the injection, you can get a little bit of redness, a little bit of tenderness. Usually goes away on its own after a couple of days. If it lasts longer, topical medications, topical steroids usually help calm it down, and usually alternating sites of involvement will help with that. So I counsel patients on the risk of injection site reaction. The second thing is slight increase in your risk of upper respiratory infections. We know that's the case with most of our biologic agents, where things like the common cold, things like flu, now it's getting into flu season, even COVID, you can see slight increases in terms of your risk for that. So I do counsel patients on those. Now let's shift gears a little bit. We saw the slide previously, and we kind of covered the things on the left-hand side here, your high impact sites, different skin tones. That's a visible study. Now let's shift gears a little bit and talk about active psoriatic arthritis here. So remember how we have 6 different domains of psoriasis, psoriatic arthritis. 5 of those domains are involving systemic disease with your nails, with your axial disease, with your enthesitis, dactylitis, and your peripheral arthritis. This is a separate study looking specifically at adult patients with active psoriatic arthritis. Again, 2 parallel arms, the Discover 1 study and Discover 2 studies are the pivotal studies for Tremfya here. In psoriatic arthritis, what we love to see is what we call the 60-40-20 breakdown. So roughly that translates to an ACR 20 response of 60%, ACR 50 response of 40%, ACR 70 a response of 20%. And you see out to the 1 year mark, Tremfya is already exceeding all three of those measures: 75% ACR 20, 48% ACR 50, 28% ACR 70, going out, very durable response with time as well. Out to the 2 year mark, you're seeing a nice stable flat line here. So what does ACR actually measure? ACR 20 translates to roughly a 20% improvement. Now, of course, with our joint colleagues, when I'm in our dermatology clinic, I always joke with my rheumatology colleagues that they are so far behind dermatology, right? Like with skin disease, skin involvement, that we're able to reverse changes very easily. We can get the pink plaques of psoriasis to clear up. Maybe patients have a little bit of post-inflammatory changes afterwards, but that gets better with time as well. It's a completely different story when patients have any kind of psoriatic arthritis involvement. You do have a more narrow window of opportunity in order to be able to treat their joint symptoms before they get some irreversible change. And that's why you're seeing lower numbers overall across our psoriatic arthritis trials. Now, for our psoriatic arthritis studies, the good thing is there's actually no new safety signals seen. In fact, I point your attention right here, when you take a look at things like serious adverse events, you look at things like infections, you take a look at things like serious infections, you actually see lower rates in the Tremfya arm compared to the placebo arm, right? So you actually have more patients getting these adverse events when you're getting a sugar injection compared to the Tremfya injection. That's how safe this medication is. Same with the long-term data, through 1 year, through 2 years of data here, no new safety signals were seen. Additional safety considerations, I talked a little bit earlier about some of the things I counsel patients on: injection site reaction, upper respiratory infections. It does have very safe profile on extensive patient experience. I also want to point out what are some of the things that you do not see on the safety slides, right? So I think that's just as important to think about what we're not seeing as it is what we're actually seeing on the slides. There's absolutely no labeled warnings or precautions for things like malignancy, exacerbation of inflammatory bowel disease, candidiasis, or MACE, or major adverse cardiovascular events. So those are not things that you see with the interleukin 23 inhibitor classes in general. Those are things you do not have to questions about. Those are things that patients do not have in their package insert when you prescribe them Tremfya. So I think that's just as important, what is not present, as it is what is actually present, what you counsel patients on. In terms of liver enzymes, there's only if clinically indicated. So if patients have baseline elevated labs, you can monitor them afterwards. But there's the only lab that actually is required, and mostly by insurance companies. And what I get is a baseline TB test. So I get a baseline quantiferon gold, and then I will monitor that once a year, just mostly again for insurance purposes. But reactivation of TB is tremendously low. We talked a little bit about some of the things on the package insert. If a patient has a hypersensitivity reaction to Tremfya, you would not give a patient a medication they're allergic to. If a patient has a very active, serious infection for which they're in the hospital setting, for which they're getting IV antibiotics, you can pause treatment or hold off on starting treatment until they're done with that serious infection, and then you can restart treatment. And in terms of lab monitoring, all I do is that quantiferon gold if I do not have suspicion for any other underlying process going on. Now let's jump into a patient scenario here. So this is a patient, John, 42 years old. He has a long-standing history with moderate severe plaque psoriasis. He presents to your clinic with worsening joint pain and morning stiffness lasting over an hour. He also reports swelling in his fingers and difficulty performing fine motor tasks, such as making a fist, buttoning his shirt, or playing the guitar. So some of these simple activities of daily living that we might just on a day-to-day basis take for granted, right? Something as simple as buttoning your shirt in the morning. These patients' psoriatic arthritis are really suffering with some of these more simple and tasks on a day-to-day basis. Despite moderate control of his skin symptoms, his joint symptoms have significantly progressed over the past year. He's been on topical medications. He's been on intermittent NSAIDs for joint pain. He's been on methotrexate 15 milligrams once weekly as well. None of these have helped his psoriatic arthritis symptoms. So he has swollen tender joints in the MCPs, PIPs, dactylitis, part of that rheumatology, dermatology clinic. One of the things I learned from my rheumatology colleagues is one of the few rheumatology emergencies that they consider, urgent, emergent is dactylitis, because once you have those sausage digits, oftentimes that leads to irreversible damage to your joint. So when a patient comes to you with sausage digit or dactylitis, that is something where you need to be a little bit more aggressive on treating and calming down all that inflammation before it leads to lasting joint damage. Patient also has symmetric erythematous scaly plaques on the skin. And of course, with the baseline X-ray imaging, you see both joint space narrowing as well as joint space joint erosions here. So in cases like John's, how do you see your role in ensuring early diagnosis to help slow the potential progression of joint damage, right? So at this point, when John comes to you and he's no longer able to button his shirt up in the morning, when he has such strong and severe psoriatic arthritis symptoms, I do feel like we've really missed a big window of opportunity. I hope for patients like John, we're able to get him in earlier and get started with effective treatments like Tremfya at an earlier point before he goes through some of these more permanent damage to the joints here. So this is a case where the X-rays really will demonstrate some of the joint damage, and we get a lot of hand X-rays as well as foot X-rays. We'll again lower back X-rays as well, visualize the impact of joint damage and erosion in psoriatic arthritis. The main method of measuring the degree of psoriatic arthritis and severity is the psoriatic arthritis modified van der Heide Sharp score. What it basically takes into account is it breaks down all the joints on your hands as well as on the feet and toes, and it has a certain score for both joint erosion as well as joint space narrowing, right? So joint erosion is basically bone damage, so bone erosion with time. Joint space narrowing is more that articular damage and inflammation caused in the joint space there. So both are components of this modified van der Heide Sharp score, and that is the primary treatment outcome when we take a look. So in those in the early psoriatic arthritis clinical trials, that's your Discover and Discover 2, it was not specifically powered to look at prevention of progression of disease, right? The main purpose of those two studies was to look at, for active psoriatic arthritis, are you able to help patients with their symptoms and with their joint, objective measurements of their joints? But what Johnson & Johnson saw in their data was actually a signal for prevention of the progression of joint disease, right? So for patients on that placebo arm, they had roughly 0.95 in terms of the score change, so advancement in their joint disease with time at week 24, so 6 months into the study, whereas Tremfya had about half of the progression joint disease. This was not statistically significant because it was not powered to look for a difference. But because they saw the signal, Johnson & Johnson actually went out and invested in this completely different study called Apex. So it's a phase 3B trial to evaluate the effect of Tremfya on radiographic progression. And this time it was powered to look for the difference in terms of joint progression and really answer for us, is Tremfya able to prevent the progression of joint disease? When you think about joint space narrowing, when you think about joint erosions, can we not just treat active psoriatic arthritis symptoms, but can we take a step forward and actually think about preventing that disease progression? And this is what that data shows. So first, going over the joint symptom data, ACR 20, 50, 70. Remember, what we like to see is roughly a 60%, 40%, 20% breakdown. You see exactly that with Tremfya exceeding those numbers: 68% ACR 20, 42% ACR 50, 22% on your ACR 70. Of course, the serious adverse events, very consistent with all the previous studies. No new safety signals were seen. But this is kind of that big picture. This is that big message, and this is the only IL-23 inhibitor on the market to have this kind of data. Basically, what it showed is 2.5 times less radiographic progression with Tremfya at week 24, based on the modified van der Heide score compared to placebo. So your patients, when they have psoriatic arthritis, when you start them on Tremfya, they are 2.5 times less likely to progress with their erosion, so kind of bony structural damage and structural changes with their joints, as well as that articular, that joint space narrowing. So compared to placebo, 2.5 times less progression. Again, it's the only interleukin-23 inhibitor proven to significantly inhibit structural damage progression. So it's the only one that has this data. So for our patients with psoriatic arthritis, thinking about prevention, that data I think is really important. Now, when you separate it out by those two factors, thinking about bone and then thinking about the cartilage, the bone is this erosion here, so about 2 to 3x less progression here. And then when you take a look at joint space narrowing, about 2x less in terms of joint space narrowing. So when you break down the individual factors, you see good difference there between placebo and Tremfya as well. How about in those patients with really bad psoriatic arthritis? You take a look at their skin. Very good results here as well, looking at PASI 90 as well as your IGA 0/1 response. So in those patients who are oftentimes a little more advanced in their disease, they're seeing really good clearance on their skin as well. Taking a look at different quality of life indexes, you see a really good when the lower the score, the more reduction from baseline. It means the better the patients are doing. And this is a composite score that takes into account different activities, things like dressing, getting out of bed, eating, walking, being able to do their daily hygiene, things like brushing your teeth, gripping things that you need to grip, daily living. The lower the score, the better that patient is functioning, and so you do see significantly lower scores on Tremfya compared to placebo as well, meaning that what we're seeing radiographically is translating into meaningful outcomes for our patients, right? So we don't just want to treat x-rays or numbers on a page. This is showing that reduction in your progression of joint disease, that reduction in your joint space narrowing and the bony erosions is actually translating into meaningful outcomes for patients' ability to dress themselves, to eat, to actually brush their teeth and walk. Those are all really important things. So it's good that we have this measure as well. Going back to summary, we took a look at the skin, we took a look at the joints. There's a lot of different clinical trials. Johnson & Johnson has really kept the trial lists really busy around the world. A lot of different studies looking at the skin with psoriasis. We talked about the visible study, specifically looking at skin of color. We talked a little bit about the spectrum study, which is that study looking at lower body surface area involvement, but patients with psoriasis with special sites of involvement. And I think this is also a point I really like to stress in these talks, is that over the past 5 years or so, how we define moderate severe plaque psoriasis patients has really advanced and has really changed for the better. Right? Traditionally, say 10 years ago, we used that pretty stringent criteria of body surface area to define who should be considered moderate severe. Right? So 10% is still that clinical trials cutoff. When you have 10% body surface area or higher involvement, you're definitely a moderate severe patient. You should definitely be on a systemic agent. But what the International Psoriasis Council and a lot of us dermatologists realize is when you have just the body surface area of involvement as your cutoff, you're really missing a whole lot of patients with psoriasis who are just suffering in silence, being on topical medications with systemic inflammation. So what the International Psoriasis Council actually came out with a recommendation a few years ago is to redefine the way we think about moderate severe psoriasis and which patients should be on systemic agents. Now, there's 3 different ways we categorize these patients. The first is still that traditional clinical trial definition. BSA 10% or above, that patient should definitely be on the systemic agent. The second way now is this low body surface area, as low as 1% body surface area, but high impact areas of involvement. So when patients have lower body surface area, but impacted sites like your scalp, like your face, like intertriginous areas, like palmoplantar involvement, like axillary involvement, like genital involvement, these are all high impact sites, not just because they are traditionally harder to treat, but also because they might be more visible or they might have an outsized impact on the patient's quality of life. So even if they have lower body surface area, the International Psoriasis Council does recommend these patients be on systemic agents as well. And the third category of patients who should be on systemic agents based on that IPC guideline and recommendation is patients who fail topical therapy. For patients coming back in follow-up and they're not at treatment go, and for me, again, treatment go is 100% clearance for my patients. If they're not at that go, the International Psoriasis Council does recommend those patients also be on systemic agents. So I think that recommendation is pretty clear and has really helped a lot of our patients out. So that's your plaque psoriasis, your skin psoriasis. Of course, a lot of clinical trials and ongoing studies in psoriatic arthritis as well. APEX is part of this group as well. Ulcerative colitis, we know Crohn's disease, different indications. Our GI colleagues use this medication. Rheumatology colleagues use this medication as well. Most recently, the Tremfya is approved in pediatric patients 6 years of age and older who weigh at least 40 kilograms as well, being the only interleukin-23 specific inhibitor with this indication for our kids. 15 years of clinical trials experience, 25 ongoing and completed studies, over 230,000 patients treated in moderate severe plaque psoriasis as well as active psoriatic arthritis. Now, how do you get patients on this medication here? 6 injections per year. So, it's a pretty optimized 8-week dosing schedule where you start at week 0 with an injection, 4 weeks later, again, another injection, and then the maintenance dose is once every 8 weeks thereafter. The exact same dose, exact same injector, regardless of, sex, BSA involvement, severity of psoriasis, regardless of weight, regardless of body surface area. It's really easy for our patients to remember to use this. It's a one-press patient-controlled injector. And I like to tell this story about how thoughtful Johnson & Johnson was with this injector. They actually went out and invested in a completely different clinical trial. It was called the Orion study. We actually did this study at the University of Pittsburgh here. And basically, the point of that study was to show that even patients with psoriatic arthritis, so those with poor joints and pain in their joints, are able to use this simple one-press patient-controlled injector. So I think that just really goes to show you how thoughtful this whole process with designing this medication and the injector has been. That study did have a positive outcome, showing that patients did appreciate having this injector. It's available in 2 different dosage forms as well. We talked about getting a baseline tuberculosis test. I just get the quantiferon gold prior to starting patients on this medication here. Now, in terms of coverage, I've had really good success here in Pennsylvania with our Medicaid coverage, and then of course commercial insurance patients in psoriasis as well as psoriatic arthritis across the country, nearly 100% commercial coverage. And of course, for any patients on commercial insurance, there's also a really good bridge program. It is a preferred first-line coverage on the majority of Medicare Part D plans as well. Some of those plans are listed on the bottom here, but your local reps would be able to help guide you with any coverage questions. But it's really made life easy for my 2 biologic coordinators. Whenever I write Tremfya, I feel confident that my patients are able to get this medication. So how does the structural damage data and efficacy and safety across key psoriatic domains influence your decision to use Tremfya earlier in your appropriate patients with active psoriatic arthritis? We really have to think about this all as a chronic systemic inflammatory process. It's not a separate process where patients get psoriatic arthritis and patients get psoriasis. All at the end of the day, all the mechanism for the pathogenesis of disease have a shared pathway here where you really need an agent, thinking back to that mechanism of action slide where you have the 2 parts of Tremfya. You have one part that binds to the CD64 that targets the monocytes and macrophages where interleukin 23 is produced. You have the other part that's really shutting off that pathway, binding to the P19 subunit of your interleukin 23. Again, going back to that first slide here, Tremfya is the only interleukin 23 inhibitor to prove significant inhibition of structural damage progression, so not just for the skin, but also for the joints. With that, thank you for your participation, and I would be happy to take any questions at this point.
Remember, if you want to submit a question to our faculty, please submit a question in the question chat pane on the right-hand side of your screen. And also, if you think of any questions afterward, you can also contact us at info@educationalseries.com.
Dr. Tung, I thought that was fantastic. Thank you so much for that talk.
No problem.
With a few questions I have for you, with this new data, what do you say the PSA data that you walked through today, does your treatment algorithm change when choosing a biologic for your moderate to severe psoriatic arthritis patients?
Yeah, that's a really good question. And, I think the biggest winner here is our patients, right? Anytime, you have really good data coming out, I feel like it, Skyrizi comes out with really good data, Tremfya comes out with really good data. All the biologic agents, are always kind of advancing the field as a whole. And I think, I don't see these agents as competitors against each other per se. I think the biggest winner is going to be that population of patients I kind of touched on at the end, those moderate severe plaque psoriasis patients and psoriatic arthritis patients who are only being managed by your traditional, DMARDs, your immunosuppressive agents, your topical medications. There's a whole lot of unmet need of patients who are underdiagnosed and undertreated, would suddenly be able to benefit if we just recognize the disease process earlier on. In terms of thinking about the treatment paradigm and the biggest change, to it, I think the biggest difference here is going to be that pediatric patient population, right? Traditionally, those patients 6 to 18 years of age, before 18 and over, they not had an interleukin-23 inhibitor. Right, you have IL-12 and 23 inhibitor with Stelara, but this is the first interleukin-23, so that becomes suddenly first-line interleukin-23 inhibitor for all our pediatric patients. Now, for our patients with psoriatic arthritis, I think the joint progression data is really important when we have patients, and we're able to diagnose them early. Now, to be able to tell that patient, look, we're not just going to help you, with your active inflammation, but we're going to, think about the next 20 years, the next 30 years, and be able to prevent that progression. I think that puts Tremfya really early on in our treatment algorithm as well.
Awesome. Thank you so much. When deciding which IL-23s to choose for moderate to severe psoriasis patients, does this data make you lean one way or the other?
It does. For my patients with active psoriatic arthritis, kind of that last point I made is, if patients are coming into you with active psoriatic arthritis, we're talking about prevention progression of joint disease. This being the only interleukin-23 inhibitor with that data, I do think that's a patient population that would really benefit from starting Tremfya. Now, of course, not a big knock on the other IL-23 agents. I think they're great agents for the appropriate patients. I think, again, at the end of the day, this whole field is getting elevated. I think, we have really good new therapies for all our patients. And I think it's just about really diagnosing them earlier, getting them to seeing specialists earlier as well, and just getting them started on one of these biologic agents.
Awesome. And one of the last questions I have for you, what would you say is the role of IL-17s in treating patients with moderate to severe psoriasis, in your opinion, moving forward?
For sure. Now, IL-17s, continue to be, I call them the Ferraris of our biologics for psoriasis, right? We know the interleukin-17 pathway being downstream of interleukin-23 is just has a faster onset of action, right? So for our patients, I kind of describe it to colleagues as kind of like using systemic steroids. Of course, we don't ever want to use systemic steroids in our psoriasis patients, but when you want that, that steroid taper effect, that really fast onset, patient has a big, wedding coming up, or a patient has, big events coming up, patients, up at night, not able to sleep because of their psoriatic arthritis or their psoriasis. I think that interleukin-17 definitely still has a role to play in all of that. The other piece of the action where interleukin-17 continues to be the only class that has good data is axial disease, right? Axial disease, axial spondylitis, that's another domain. We talked about the 6 domains of psoriatic arthritis. The axial domain still belongs to the interleukin-17 class. But I think with newer data coming out, especially with this latest Apex data for Tremfya, the interleukin-23 inhibitor class is looking really good for many of our patients, moderate severe plaque psoriasis, our pediatric patients with psoriasis as well, and our psoriatic arthritis patients too.
Awesome. Thank you so much for answering all the questions. That's very helpful.
Yeah, well, I'm always happy to address any questions as well.
Well, thank you so much, Dr. Talia, Dr. Tung, for this really interesting presentation. And also thank you to our supporter, Johnson & Johnson Innovative Medicine, for making this educational event possible. Now that this part of the webinar is complete, we'd like to invite you to join us on Tuesday, October 28th, 7 to 8 p.m. Eastern Standard Time, when we're going to be talking about clearly target RY and the lasting marks of acne with Dr. Kate Holmcomb. So thank you so much, everybody, for joining us. Have a good evening. Bye.